So for Dr. Mohammed Hassanin, some patients eat a full meal right after azan, and some of the patients after they have to pray first. So which igarlixi has been advised to be injected an hour before biggest meal. So what is your tip on timing of injection during Ramadan?
Sure, thank you very much for the question. Obviously, individualization here is key. If someone's going to have their biggest meal a bit later, then they would have the injection closer to that time. The vast majority in the study were taking the injection just before iftar, without a gap, obviously because they're fasting and you don't want to inject insulin an hour before the meal, before Maghrib time, when they are fasting as well. So the vast majority of the investigators and the patients were taking the injection before the iftar. For some, of small minority who their main meal was at suhoor, they were taking it suhoor as well. So I think in Ramadan, we can stick to the injection being closer to the time of the biggest meal, whether that is iftar or an hour or two later or suhoor.
Okay.
So since we don't have question in the question board, we can have a discussion among the panel then. Okay.
Yeah.
Dr. Zanaria, from data, Dar global study have shown that incidence of prevalence of hypoglycemia among patients treated with human insulin, in fact, lower or similar to those on analog. On other hand, we have many data to show that analog have better profile than human insulin. So what your comment on some of the practicing physician or doctor changing human insulin to analog when patient going for Ramadan fasting?
Thank you, Prof. Wan. I think what it means is that we're doing well in terms of actually instituting probably patient education and treatment adjustments, as well as probably SMBG, and all this actually on top of is probably what is going to help us reduce the rates of hypoglycemia among patients on insulin generally. In real life setting. Of course, in the clinical trial, everything is optimized. Patients are being given the benefit of monitoring very regularly, and so actually in the real world, we can still stick to human insulin, and I know in Malaysia we still do a lot. Probably the background of whether they are already having hypos in the past would actually make us decide whether we really need to switch. Yeah, Dr. Hassanin.
Thank you. Thank you.
Professor Wan, may I comment here?
Sure. Yeah.
The survey, I saw myself the data because as Dr. Zanaria was analyzing the data, we were also analyzing it in a different way. And the survey was not meant to have these types of comparison. We're just trying to understand. But if you look into the subgroup analysis, you will find, for example, that human insulin were used much more in certain countries, certain profile of patients, certain levels of complications. So it's not like a proper study where you have two arms with everything being equal, and then we're saying they are better. But the feedback is that patients on human insulin are perhaps not doing too bad. The next step, inshallah, for us to analyze from this beautiful survey is diving a bit more in depth into those who had hypoglycemia. Who are they? What type of treatment they're on? What is their profile, or even which countries or regions they're from? Perhaps taking the information from the end of the spectrum would be helpful.
Thank you. Dr. Muhammad, in your result of Soli Ramadan's trial have shown that incidence of hypoglycemia is so small, okay?
Yes.
About 4 patients, isn't it?
Yeah.
Do you have a data on those who have hypoglycemia? How many of them on sulfonylurea at the same time?
Well, we have started to look into the subgroup analysis, but to be honest with you, because the number of patients are so small,
I know.
it's difficult really to do a proper subgroup analysis. 43% of the study group were on sulfonylurea as well. So perhaps you will end up naturally with 2 of them on sulfonylurea and 2 or not. I don't think we can make much out of this. The good news from the study is having such a type of therapy with the education and the attention the patients were taking in a study, even though it's real world and observational, led to very low rates of hypoglycemia, while HbA1c was reasonable at 7.5 at the end of the study.
Agreed. Okay. Any more comment from?
Maybe I could, can I ask for Dr. Mafauzi? Yes, I can see in your slides that the study for SGLT2 inhibitor, which is unfortunately you have only 2 studies, empagliflozin is not there because they don't have the study yet maybe. So the question is, you said that the hypovolemia is much higher in the SGLT2 group. So are you suggesting people with the heart failure, because some of the patient using SGLT2 inhibitor is with the heart failure, are you suggesting them in the Ramadan they should drink more, or how are you gonna deal with it?
What you have to probably play by the ear to the patient. In fact, probably for people with heart failure may be advantage because it's hypovolemia. They will probably be have less volume and less heart failure if they are on SGLT2. So in fact, it may be an advantage for this sort of people with heart failure. And as I'm sure the SGLT2 now is the drug for cardiologists. They use it for any patients with established coronary artery disease. Once they had heart failure, almost all of them will be on SGLT2. So I wouldn't be too concerned. If in fact, anything, will probably be a slight advantage for patients who have heart failure on SGLT2. Perhaps they probably be less symptomatic and probably less likely to have an exacerbation of their heart failure during Ramadan. But nevertheless, I think you should probably play by the ear, go by. And of course, people with heart failure, they are considered as very high risk category. And you really have to sort of risk categorize these patients very carefully before you advise them on they can fast or not.
Yeah, as you know, the patient sometimes.
Other small comments.
Yes, please, Dr. Mohammed.
There is a
Professor
question
in Bangladesh presented a
Sorry,
study.
Doctor. Sorry. Yes, please continue, Dr. Hasanin.
Please.
Sorry, I'm saying that yesterday Dr. Pathan presented their study from Bangladesh on empagliflozin with a very similar outcome on other SGLT2 inhibitors. So tolerability is high and low rates of hypoglycemia. It's important to remember in my study on canagliflozin, yes, we reported higher rates of symptoms of volume depletion, but that did not stop the patient from fasting. In fact, the arm of sulfonylurea was higher. So people felt thirsty, felt a touch with the thirst and other symptoms, but it wasn't enough to stop them from fasting and did not have any impact on their renal parameters.
Okay, okay, thank you very much.
One question for Dr. Zanaria. Are there recent data on newer generation long-acting basal insulin analog such as glargine 300 and degludec for fasting in Ramadan?
I think I did show the slides in
I know, yeah.
About glargine 300, and it was degludec and aspat, but I'm not sure about whether degludec alone has a specific Ramadan study.
Okay, I think Dr. Muhammad, I think we can stop this session and follow with the next session. Thank you very much for everyone. Thank you. Assalamualaikum warahmatullahi wabarakatuh.